pedir para o pessoal do IDOR isso, começar a gravação. Obrigado. So, first of all, Professor Ronco, it's a great pleasure to welcome you today to our National Nephrology session of IDOR. And I would also like to thank Thiago for his presence and for making it possible to you to be here today. I think Professor Ronco don't need any kind of introduction. And just to know, Professor, we are from IDOR, the largest health service company in Latin America. We have a network with almost 69 hospitals, medical centers, labs, and outpatient dialysis clinics, and several other services. And today here we have a lot of nephrologists from all Brazil, a lot of states of Brazil here, and we are very excited to listen your talk today and what you have to say. So thank you very much, and please.
Well, thank you very much. First of all, the only word that I know in Portuguese is obrigado, but it's a very nice start. And in fact, I want to thank you for having invited me to share a little bit of our history concerning our research and education at the Vicenza Institute and the Department of Nephrology of our hospital. A quick word about our hospital. It is 1,000-year-old, and it has been going through several renovations until today is a very modern structure, but the cloister, 1,000 years old, are still there. It was originally the site of the first university in Italy, and then the university closed, and after a few years it opened up in Padova, and I belong to the University of Padova that is this year having 800 years of history. Coming to the more, let's say, recent history, we started our international courses in 1982. We had at that time a kind of rotation in terms of topics, and some of you may remember that we started with peritoneal dialysis, and then we did hemodialysis, and then we immediately started in '84 with the critical care nephrology. Critical care nephrology is one of our, let's say, core business. The reason for this is that we encourage from the beginning people to cooperate in terms of diagnosis and care of critically ill patients. And you probably know our books published by Elsevier with Rinaldo Bellom and John Kellum, entitled Critical Care Nephrology. But Vicenza is the place where the term critical care nephrology was born, and today this has become a real subspecialty or a specialty. We, with Rinaldo, wrote an editorial very early after one of these courses, advocating the need for intensive care fellows to spend time in nephrology and for nephrology fellows to spend time in intensive care in order to speak the same language and to operate in a very coordinated way. I would say that the 80s were mostly characterized by the attempt to optimize the extracorporeal therapy. I remind you that we started with arteriovenous hemofiltration without any blood pump. And the reason for this was that while we nephrologists were used to blood pumps in dialysis, the intensive care nurses were not really liking extracorporeal circulation and blood pump, and therefore arteriovenous hemofiltration was considered a safe and simple therapy. But very soon, we found that the amount of dialysis and blood purification that we were delivering was probably insufficient due to the low blood flow and the low amount of ultrafiltration. And therefore, we tried to incorporate in intensive care part of the machines or pieces of the machine, like the blood module, the ultrafiltration control module of chronic dialysis machine. And we did what we call adoptive technology, which was basically a system made of different components that unfortunately were not talking to each other, and the possibility of errors and mistakes were very, very, very high. So the real revolution, I think, after we discovered that we could use diffusion together with convection, and in some cases we even utilize convection and diffusion together. There is a first paper we published in the International Journal Artificial Organs speaking about hemodiafiltration. The real revolution came when we designed, in conjunction with a company called Hospital at that time, the machine called Prisma. Prisma was designed specifically to be utilized in intensive care and critical ill patients. And the advantage of this machine was that the critical points for ICU nurses, which basically were the priming and the starting of the therapy, were facilitated by a self-loading of the blood lines and the dialysis lines. After some times, different companies developed different machines, and in our courses, every year we had hands-on sessions to try to identify exactly what were the complications, what were the indications, where were the characteristics of the different techniques. In the meantime, there were also presentations in our meeting concerning the evolution of membranes that we utilized, because not only the high flux membranes appeared in the scene, but also membranes with increased biocompatibility. Some membranes with heparin coating the fibers inside, derived from a special license that Bentley used in the original ECMO circuit, etc., etc. There was an evolution also, although limited, in the pediatric blood purification system with mini filters. Nevertheless, I think that one of the important really step forward was around the year 2000. We had begun in 1995 to collect data in a prospective randomized controlled trial, delivering different amounts of dialysis, and this was 20, 35, and 45 milliliters per kilogram per hour, which represented 3 different doses to be delivered to critically ill patients. And I remember that this is a message for the fellows: if you want to have a study done, you have to do it yourself. I remember spending days and nights in the ICU, where fortunately we had a very good collaboration. But I presented in the year 2000 this paper that we published in Lancet, where we described that there is a correspondence between dose of dialysis and survival. Only after a certain point, you reach a plateau where increasing further the doses of dialysis does not result in further survival. Our threshold value was the 35 milliliters per kilogram per hour. And until 2 studies performed in the United States, the ATM trial and the renal trial in Australia, a different plateau was found specifically at 20 or 25 milliliters per kilogram per hour. But again, I think that these studies demonstrated a few important concepts. One, continuous therapies were definitely the therapy of choice in severely unstable patients. And there were discussions about randomized trial not showing any difference with intermittent therapy. But in most of these studies, people that could not tolerate intermittent therapies were not enrolled in the study. So basically, this was a clear definition that continuous therapies were a must in severely ill and unstable patients. The second point was that you need to dialyze patients enough to be sure that under-dialysis is not a cause for mortality. And based on these two concepts, exactly in the year 2000, I was working in New York at that time, but I was continuing to produce the Vicenza courses. We founded the new entity called ADQI, Acute Dialysis Quality Initiative. And the reason for this was we wanted to create a consensus group to try to identify areas of controversy and try to possibly stimulate new studies. So the first meeting was in New York, and I organized a meeting on CRT and related technology. But the most interesting meeting of ADQI was the second one we organized in Vicenza in 2002, where we gave birth to RIFLE. For the first time, there was a common shared definition of AKI. We agreed that although acute kidney injury may not represent exactly what happened in the kidney, we wanted to use a harmonized, homogenized terminology. From that moment, many studies have demonstrated that when you move from non-AKI to stage 1, 2, and 3, or R, INF, let's say, stages, you increase mortality, hospital and ICU length of stay, you increase cost, you increase major adverse kidney events, and the level of possibility to restore and come back to normal renal function is reduced in these patients. From that moment, almost every year when we did the Vicenza courses that contained the, let's say, extraction, the distillation of what was the hot topic in those days, we also organized other ADQI meetings in conjunction, including CRRT in cardiac surgery, management of fluids. Fluids has always been something that we discussed heavily in our meetings. Another was about hepatorenal syndrome. And finally, in 2008, we made a meeting on cardiorenal syndrome. Again, today, some people publish about cardiorenal syndrome. I have seen a paper recently that did not even quote our first paper, but you might remember that our first definition classification was published in 2008 on the Journal of American College of Cardiology. And then moving forward, in the meantime, technology was developing. So we moved to a new generation of CRRT machines, a new generation of membranes, and we inserted the concept of MOST, multiple organ support therapy, that today is better defined probably with the term ECOS, extracorporeal organ support. Fluid, as I mentioned before, was presented in several ways, including the fact that we did the DORE-MI-FA study showing that there is a continuous function of relation between fluid overload and mortality. In the meantime, around 2013, we also presented our first result with the Carpe Diem machine, which is a special machine for neonates that we generated, produced, and designed in our institute. And only subsequently, Medtronic took this development and brought it to the market. But originally this was designed by our department and by our group. In our system, our model was always what we call the round table of science. We always tried, thanks to the presence of international fellows, and Dr. Tiago Reis is one of these, to put together a strong relation and crosstalk between different disciplines, including biology, including dialysis, including nephrology, but also including engineering, physics, mathematics, pharmacology, etc. Having this kind of approach allows us to generate protocols and studies that are economically sustainable and that make sense from the perspective of different disciplines, so that specialists in different areas are involved. And I think that this was what gave probably birth to our interest in so-called subclinical AKI and in the study of renal functional reserve, leading to the application of biomarkers. One of the last topics we utilized as a subject of discussion was the different membranes in one side, but the other was also the application of extracorporeal blood purification therapies in COVID patients. And this led to 2 editions of our courses that were virtual, and unfortunately we were quite tired to see each other through a screen of a computer. And thanks God, this year in June we were able to make a version of our course back in person, and we have we had almost 500 people attending, which is a great satisfaction, because it was a beta and we really didn't know what it was. So this is a very short, let's say, overview of what I did over this year, what our group did over this year. Next year will be the 41st anniversary course, but I'm sure that Dr. Tiago will be very precise and very excited in somehow summarizing what he learned and what he presented, as well as member of the faculty in the course of this year. So you're all invited to join next year, because finally we could travel again, and hopefully we can also exchange information. 2 aspects that I want to mention. There is nothing that substitutes personal relations and personal discussion, certainly not a Zoom meeting, with all the respect with the present meeting, of course, but I think relationship in person are very important. The second point that we have clarified over the years is that there are questions that cannot be answered by randomized controlled trials. If you wait to have specific evidence, as in the case of drugs where they recruit 8,000, 10,000 people, you can wait forever. The story of the history of extracorporeal blood purification therapy is a demonstration of a small incremental improvement with progression year by year, without, let's say, hard, solid evidence demonstration by a randomized controlled trial. Nevertheless, we know that the survival in sepsis has improved, the survival in AKI has improved, and we are treating more and more patients with complicated and sophisticated pathological situations. I'd say one thing last, which is we are exploring now a new frontier, and the frontier is the use of sorbents in the extracorporeal blood purification therapies. Well, let me tell you that we are today where we were approximately 40 years ago with the CRRT, and we were full of uncertainties at that time. There were people that were strongly nihilistic, and finally today everybody is using CRRT. I hope it will not take another 40 years to optimize our sorbent therapy, which in my view is offering further options to our patient. We cannot content ourselves. We need to explore new boundaries. We need to stay on the edge of the progress, and with the help of our scientific rigor in one side, but also the humanistic approach to medicine and the view that sometimes we need to dare for, as the Star Trek group will say, to boldly go where no man has gone before, is probably the right approach to make sure that progress in medicine continues. I close here, and I leave the word to Tiago. Thank you very much.
Thank you so much, Professor. So I'll start the slides here. Thanks, Bruno, for organizing this meeting and for the kind invitation. So these are my disclosures. And the framework of this lecture will be the 2017 course, which was my first edition there. And the question is, how is the future? And this lecture today theme is the course as being a window to the future. The publications on each of those topics, the reality in Brazil now, and how was the last version of the course in 2000 and this year. So this was me in the first course, and back in 2017 concerning urinary biomarkers, we didn't have them in Brazil. Concerning removal of CO2, we didn't have it as well. High and mid cutoff membranes, hemoperfusion with cytosorb, hemoperfusion with Chafram, machines such as Omni Multifiltrate Pro, and things like NGAL, Seraph, Chafram, HF20, and Carpedine, they were not available. Now, in 2022, only 5 years after that, we have all those therapies and devices available, and only a few that will be in the near future also available. Starting with biomarkers. So in that course, I was presented to the concept of subclinical or subfunctional AKI, and we've published on that. And in brief, this means that we have here in the left part of the figure the normal status of the kidney, so no injury or no dysfunction. And we have this new stage, which is the subfunctional AKI, in which we have increment in damage and injury biomarkers, but not in dysfunction biomarkers, which is the creatinine and urinary output. We have the functional AKI, in which we have a reduction in urinary output or an increment in creatinine. For example, when we start glyphosines, when we use iodinated contrast, but no increment in damage or injury biomarkers. And finally, we have the stage that we all know, which is when we have combined increment in creatinine, reduction in urinary output, and also increment in urinary biomarkers. And now we have this available in Brazil. So it started in this year, and then we can apply this to our patients. We don't have yet NGAL. I saw it there in 2017, and would be a complementary also biomarker. And always when we talk about biomarkers, we have this little guy here, the skeptical guy, the nihilistic guy, asking, are biomarkers really useful? Well, we published this year. It was a review on cardiorenal syndrome, and we did this visual abstract on the PrEP AKI trial by Zarbok. So in brief, in this trial, patients undergoing cardiac surgery after 4 hours of cardiac bypass, they had measured a nephrocheck in urine. So if nephrocheck was above this threshold of 0.3, patients were randomized to either the KDIGO strategy of prevention of kidney injury or the standard of care. Well, there was no difference in the prevalence and incidence of AKI. However, the more severe stages of AKI, 2 and 3 and 3D, were less frequent in the group that applied the KDIGO criteria. So this was the bundle on the left part concerning how it was the management of hemodynamics with crystalloids, vasopressors, and here in the right part, the elements in the bundle. One of the elements, it was, for example, close monitoring to serum creatinine and urinary output. So many people can say, oh, we already do that in our ICUs. We measure creatinine, but in this fashion, like twice a day, it's not so common. Another thing, urinary output was measured and reported every 2 hours. And usually we see that every 6 to 12 hours. So this leads to more accurate and more dynamic changes in the management of those patients. This year in Vicenza, we had this session on biomarkers. And one lecture that caught my attention was by Christian Nushag about biomarkers of kidney function. So I was talking about biomarkers of injury, but this lecture was interesting because there is a biomarker called proencaphalin, which is more dynamic than creatinine to see kind of real-time GFR. So it's already commercialized under the brand name of PenKid, and this was quite an interesting lecture. Well, concerning machines and devices, first with the membranes, as Professor Ronco said, we have the high cutoff and median cutoff membranes. We've published about that in randomized trial, in a retrospective trial. We published reviews and also reviews about metamolecules, because the new definition of metamolecules is related to our ability to remove those biomarkers with toxins with different membranes. We've published this in the Brazilian Journal of Nephrology, demonstrating the membranes that we have available in Brazil, and they are the things that we have now are things that people have in any part of the world nowadays. So as I mentioned, we published a retrospective trial on that. And in Vicenza in 2017, there was this high cutoff membrane, the Theralite, which was applied in patients with multiple myeloma to remove kappa and lambda free light chains. And in Brazil, we have this kind of membrane from Fresenius, the IMIC-2. Now moving to removal of carbon dioxide, CO2. So we've published a review on expanded indications for CRT and comprising also ECOR. And I was surprised back in 2017 with this device. It was called Prismalung, a device attached to a CRT machine that enables the removal of CO2. It was the first time I saw it, so I was kind of mesmerized with this possibility. And then during the pandemic, this was explored here in Brazil, first in improvised fashion, and then with machines dedicated to this aim. So this is the machine from B. Brown, Omni, and this is the machine from Fresenius Multifiltrate Pro, and IDOR was the first to apply these therapies, first in São Paulo and then in Brasilia, in Brazil. Baxter also has this device, but it's not commercially available here in Brazil. One interesting thing is that in the right is the device in series with the CRT, but also it can be applied in a standalone fashion. And back in 2017, I saw Omni CRT machine for the first time. And only 2 years after that, we had it available in Brazil. And we run one of the first therapies with this machine. So here in Brasilia in 2019. I saw there as well the Multifiltrate Pro machine in 2017, and now I think almost all hospitals from IDOR, they have this machine available. Now changing to hemoperfusion. One of the most interesting sessions in the course this year was about adsorption, a new frontier. So it started with Professor Bellomo mentioning the rationale, and then moved to Professor Ronco with more technical aspects. And finally, John Prohl talking about a specific topic, which is artificial liver support, or DP mass. So we've published this last month, hemoperfusion in the intensive care unit. So this is the representation of a cartridge and its components here on the right side. So we have the cylinder. It looks like a dialyzer, but it's not a dialyzer, with some beads inside of it. And we have here these spheres that we call beads, where the blood flows through. So this represents the small spheres, the small beads. We have two stages where the blood goes in between the beads, called interface, and when the blood gets inside each of the spheres, called intraphase. So this is the representation of a sphere, and this is how the blood flows in between the spheres. So the most important part is not the interface, but is the intraphase, when the blood goes inside the beads. And this represents that phenomenon. So this is the cross-section of the bead, and the molecules are adsorbed when they are trapped inside the beads, not only on the surface. Back in 2017, CytoSorb, one of those devices, was not available in Brazil, but during the pandemic, so in 2020, here in Brasilia, we performed the first therapy with CytoSorb in a patient with hyperinflammatory state. And now we have available in Brazil also the cartridges from Jeffram. So I saw them back there in 2017, and just last month, our regulatory agency called Anvisa gave the approval for these cartridges. So you can see there is a huge portfolio for different therapies from Jeffram. We do not have yet this machine. It was displayed in this year's course called HF20. And this machine allows the therapy, different kind of therapies to be applied for hemoperfusion. One of them, called DP mass, for artificial liver support, applies two different cartridges and is able to remove this range of molecules. So inflammatory markers, myoglobin, and this is the example of that therapy. So DP mass stands for double plasma molecular adsorption system. So in brief, the blood goes from here, passes through the blood pump, gets the citrate, and then goes through a plasma filter. So this is not a dialyzer, but a plasma filter. 30% of the plasma goes in a parallel circuit, passes again through another pump, and then in series passes through two cartridges, and then returns and merges with the blood in the bubble trap here, and then is returned to the patient. Another kind of treatment that we don't have available yet in Brazil is called plasma adsorption perfusion, PAP, which also utilizes a plasma filter, but only one cartridge for plasma perfusion in this case. As Professor Ronco mentioned, Carpe Diem is not available here in Brazil. So this machine is aimed to perform CRT for neonates, but also all the therapies like plasmapheresis. And now it was first commercialized by Belco and now it's being commercialized by Medtronic. And I think that in the near future, maybe next year, we will have it available here in Brazil. We don't have yet in Brazil the toramyxin. It's a cartridge to remove endotoxins, but I think that maybe in 2024, that will be also available in Brazil. One thing that is kind of new in every corner of the world is the Seraph 100. So it's also a cartridge, but is a different kind of cartridge because it aims not to remove endotoxins, not to remove cytokines or inflammatory markers, but to remove infectious agents. For example, it is able to remove virus, able to remove bacteria and fungi. So in the top part of the figure, we have the representation of a cell membrane. So in the cell membrane, we have a molecule called heparan sulfate, and this molecule has a high affinity for bacteria and viruses. Trying to emulate this concept, the beads in the syrup, they have heparin, and this heparin has also affinity to bind fungi, bacteria, and viruses. So in cases of, for example, bacteremia, we can apply this cartridge to remove the infective agent. So this is the cartridge, and this is the cartridge in multifiltrate pro device in series with the CRT circuit. Another interesting device that was presented this year in Vicenza, and we don't have it yet in Brazil, is a machine for organ transplant, solid organ transplant, for example, kidney transplant and liver transplant. And these machines provide perfusion. You can apply warm perfusion, cold perfusion, pulsatile perfusion, stable perfusion. So, and with this, it improves the quality of the deceased organ. And another machine that it was presented this year in Vicenza is the Prime Plus from Nova Biomedical. This machine can measure a lot of electrolytes and other parameters. It's similar, but it's not the same thing as a gas analyzer. And an important electrolyte measured with this machine is ionized magnesium. So when we apply CRT with regional citrate anticoagulation, it's obvious for us that we need to measure ionized calcium, not ionized magnesium. But magnesium behaves the same way as calcium, so it's chelated with citrates, and the biologically active part of magnesium is ionized magnesium. So I presented this lecture in this year course about the importance of measuring ionized magnesium, and I think that in the near future, for CRT applied with regional citrate anticoagulation, all the manufacturers will provide different solutions and new solutions with a higher concentration of magnesium, because we are seeing with this device that patients undergoing CRT with regional citrate anticoagulation are usually with hypoionized magnesemia. And I highlight here the Brazilian delegation. So this is Rubens from São Paulo, and this is Lucas from Porto Alegre, that they were there in Vicenza. So this is the first part of the lecture, and this is the advertisement for the next course, the 41st edition of the course in Vicenza. So next summer, I hope to see you all in Vicenza. So coming to the last part of my lecture, I will talk about EDICI. So after the Vicenza course, on Friday, Saturday, and Sunday, we have the EDICI, and EDICI stands for Acute Disease Quality Initiative. So the coordinators for this year EDICI were Professor Ronco himself, Professor Louis Forti, Professor Mitra Nadine, and Professor Alexander Zarbo. And these figures are from their respective institutions. This year, it was about sepsis and AKI, and the framework is called Modified Delphi Method. So when we have contrast in ideas, we have the thesis, antithesis, and merging them, we have the synthesis or consensus. An interesting thing about the modified Delphi method is that we have the participation of almost all the experts in the Congress with the same weight of ideas. For example, this participant talks to this participant in private, with their group in private, and then they present their ideas to the whole group with different participants. For example, we have questions, and then each group is responsible for answering a list of questions. For example, this was in 2020, the EdKey about COVID, and one of the questions was, what are the possible biological and or clinical criteria for initiating, monitoring, and discontinuing extracorporeal blood purification in critically ill patients with COVID-19? And then we came with the answer. No consensus exists on the use of thresholds of specific biological and clinical criteria for initiating, monitoring, or discontinuing EBP, extracorporeal blood purification, in critically ill patients with COVID-19. Just an example. So this is the framework, the blueprint. We do a literature review. So before EdKey, we had 4 meetings, Zoom meetings, with the different experts in my group and in the other groups as well. And we did this research. And then we compile all the evidence and present that for the group. So we previously had the questions and we present the answers to the group. This is revised by the other groups. Then we discuss it in our group again, and we write the final draft. So when we have the draft, we have 2 kind of recommendations: the recommendations for clinical practice and the recommendations for future research. So this was when we were all together, all the 5 groups together, and then these were the breakout groups. So when we were divided in each of our groups. Finally, we have the grade system. So the recommendations are divided in expert opinions between strong or weak recommendation and evidence-based. So this is based on published literature, for example, meta-analysis, randomized controlled trials, observational trials, case control studies, between high, moderate, low, and very low evidence. And finally, as I've mentioned, the EdKey was on Friday, Saturday, and Sunday. And after a whole day of discussions, studying, questions, we went to social activities. So we were in Italy, La Dolce Vita, and in the first day we went to Arena Verona. So we saw an opera. So you can imagine this arena has almost 2,000 years, and all the participants went to the opera. So you can see here Louis Forni, Gianluca Villa, and all other participants. And here, Professor Ronco, Forni, John Callum, Bellomo, Mitra, Professor Mehta, and Marlies Osterman. In the second day, we went to a dinner in Venezia. So you can imagine how wonderful it was. And here I was in a boat, in a taxi boat with Professor Ronco and all the other participants from Italy. So the most important part here is not having a good time or having pleasure, is because in these social activities, we create emotional and affective bonds between different researchers from different parts of the world. And this will nurture future collaborations in science. So with almost all the scientists here, we have connections, we publish together, we share emails, we share knowledge. So this is the importance of this kind of social activities, not by themselves, but what they provide in terms of future connections. So this is the last part, and I appreciate your attention.
Very nice. Thank you, Professor Rocco, for your review and overview about your course. It was very, very nice. And thank you, Thiago, very much for your presentation. So I think we will still have time and we can open for questions. So I will ask for the people who have questions to raise their hands and open their camera and make their questions.
Professor Elizabeth.
Hello, Dr. Ronco. It's a real pleasure to listen to your presentation, and Thiago as well. It's a very long, very well presented over the years, all your work. It's very inspiring for all of us. And I have a question regarding the use of the absorption membranes and how to decide who is the patient that, you know, we live in a country that we don't have we don't have available for everyone. So how to decide who should use, or what's the best patient to prescribe absorption membranes at this point?
Maybe I start, Thiago, then you can reinforce. I think that you identify one of the crucial points. These type of therapies are not for everybody and cannot be for everybody, especially because of the cost and engagement, etc. Nevertheless, in order to make sure that we achieve positive results, we have to identify the right patient who may really benefit from this. For example, in case of COVID, we have identified patients with very high inflammatory status, high levels of interleukin-6, and immediately found a kind of normalization in the hemodynamic response. Now, concerning the devices, you may go from membranes to membranes that have high absorption capacity, for example, oxiris, etc., because absorption is an extra mechanism that helps to remove molecules that cannot be cleared by membranes. But when you use absorption, let's say the optimal idea is to use sorbent beds that are having surface area, which is 10,000 times what a normal hemodialyzer may have. Personally, I think we need to better understand when to start, how frequently to apply the therapy, for how long, and what is the dose. And in order to do this, we need what we call biomonitoring, which is rather than one specific solute, we need the biological signals in the patient. For this reason, randomized controlled trial cannot be used for this therapy. We need to identify patients that have, for example, if you want to use absorption for removal of endotoxin, you need to make sure that patients have high level of endotoxin. So you have the target for the therapy. And if you use cytokine removal, you may want to have patients that have high level of inflammation. But the target to measure efficiency cannot be, as in the case of urea, where we have a kinetics of the molecule, which is inert, because these molecules are biologically active. And therefore, we probably need to measure the biological effects. So we have chemical effects, measurement of levels of molecules, biological effects, for example, response of the monocyte, capacity to present HLA-DR antigen, capacity to improve endothelial function, and clinical effects, which are the last one in the cascade. But in order to find the positive clinical effects, first of all, you have to identify exactly this. Now, after 30, 40 years, people are still questioning when is the right time to apply CRRT, early, late, etc. So I do not expect to answer your question right now, because we have been considering this topic from the last year. But we are certainly hoping that it will not take us 40 years to respond to the question.
Thank you. Do you want to add anything, Thiago?
Yes, we now are using the concepts of subphenotyping or endotypes. It's what Professor Ronco mentioned. So we need to kind of trace a profile of the adequate patient, take into consideration clinical aspects and also biological aspects that unfortunately yet we don't know. But for example, to remove endotoxins, we have the test not yet available in Brazil called endotoxin activity assay. And if we have that, we can select the patient that might get benefit of the therapy. So for endotoxins, we have this more clear, but not yet for example, inflammatory syndromes.
It is curious. Please, it is curious that for many years the Americans somehow made jokes on the Italians and the Europeans because we were trying to individualize the therapy while they wanted the standard. And it seems they are coming back to our resolution that every patient is different from another one. And in spite, they would love to have a number that give them the possibility to start or not to start. The patient is far away more complex and therefore requires biological monitoring, chemical monitoring, and physical monitoring, and still require a doctor at the bedside. They are using electronic medical records. They would like to have an alarm and start the therapy. It doesn't work like this.
I agree. We had the opportunity to use the adsorption membrane oxides in COVID in about 14, 15 patients. And the decision was the availability at that point, and also the cytokine storm-like syndrome. And we observed a striking different outcome in those patients. And that's for me, it's what we have seen also in sepsis. And it's much more than we can put on paper, but it's the feeling that it makes a difference when we actually decide and use it in a patient, in the correct patient.
We have used the Jafron HA380 in sepsis and COVID, and we found striking difference, especially in the monocyte response and in the endothelial function of the patients. And I think this is important because at the end, you develop a sensibility to perfectly identify in which patients you may need to apply the therapy. But of course, this has to be a collegial discussion and has to be part of the experience of every single doctor. So I think that it's important for us to utilize this therapy. Now, the right question that I always make to my collaborators is, if your mother would be in the ICU with the cytokine storm, would you use this sorbent? And the answer is, oh, yes. So if you use it for your mother and forget about your mother-in-law, of course, if you use it for your mother, I think that every patient should have the same opportunity. But we should be conscious, like biomarkers, that we cannot apply this therapy for everyone. We have to apply this therapy when we may see that the benefit is there. And the number of sessions may be different from one patient to another, because there is no point to stabilize the patient and continue on one side. There is no point to stop after one session if you see that benefits may show up after 2 or 3 sessions. One more thing, remember that all these devices that absorb, including auxiliaries, and absorb antibiotics. So you have to know about the kinetics of antibiotics when you're treating these patients.
Thank you.
Professor, I have one question. My question is about the creatinine. So do you think we'll soon stop using creatinine? And if yes, how soon will regularly use another biomarker or another exam in the place of creatinine?
I will make the example of the hybrid automotive. Hybrid automotive has electric power and has thermal power, and they do not stop using thermal power. Creatinine is like thermal power. It can be used, and it has meaning and significance, and it costs very little. But it doesn't tell you the whole story. And I was discussing this morning with some fellows from the European Society of Intensive Care that are making a stage in our department. The problem of creatinine is that it does not tell you anything until you have lost at least 50% of the nephrons, which means you may have injury and damage to the kidney that damage 20% of the nephrons. The injury remains subclinical and you don't know anything about it. But 5 years later, these patients, although they are discharged from the ICU with a normal serum creatinine, they come to your office with a serum creatinine of 1.5, and your diagnosis will be nephroangiosclerosis. This is not the case. This is a sequel of an acute kidney injury which was not diagnosed. So in my view, it would be important to create a post-AKI clinic in nephrology, following up patients that have been in intensive care, because I'm sure that almost every patient got some injury and loss of nephrons.
So, any more questions? I think we have a time for another one more.
I think we're done.
I think, okay. So, Professor Ronco, I'd like to say one more time, thank you very much for your presence here today. It's all very nice to listen to your talks and the way that you inspire generations of nephrologists. And I hope maybe I'm going to be next year in your course, and I know that's going to be a very great time if it's possible. And Thiago, thank you very much for your partner, and it's always very nice to look to new frontiers in the nephrologists and the nephrologists, and this is something that we always talk about and you always do. So I'd like to finish today, and Professor, please come back more time here to our session to talk with us.
And you may join the Cappuccino YouTube channel.
Okay.
I have one more question for the Brazilian colleagues. Do you have a good football team in Brazil?
Yes.
Okay, I'm just joking. Just joking. Take care. Thank you very much.
Okay, bye-bye. Thank you.
Bye-bye.
Arrivederci.
Arrivederci.
Ciao.
Ciao, Elizabeth.